This is the Neurosurgery Podcast.
Ready. Welcome back to the Neurosurgery Podcast. We are still here in Central Park, New York City at Rick Comatar and Jeff Bruce's charity softball tournament. Shout out to Columbia, shout out to NREF. It's a beautiful day. Last year we were rained out. This is amazing. The temperature's perfect. I want to introduce our listeners to John Wong. John, welcome to the podcast. First time on, right?
Yeah, thank you.
John, tell us your background, like where you're from, where you grew up, where you got educated.
Yeah, so I trained at the University of Alberta in neurosurgery, then completed my fellowship at Yale. In open vascular.
And, with Marat.
Marat actually was the chief resident at that time.
He looks older than you, though.
I won't comment on that.
Okay.
But
so Osama Wad was there at the time.
That's right.
His
That's
son.
right.
Okay, shout out to Osama Wad. Yeah.
That's right. Yeah. And then after that, I did 2 years with Alex Berenstein in New York.
Okay, great.
So this is like a homecoming to me as well.
Yeah, Alex Berenstein. Wow, those are real shout outs from the past. So you're a neurosurgeon.
That's right.
But you do endovascular treatment for aneurysm, stroke, stuff like that.
Yeah. I was one of the first dually trained neurosurgeons.
Okay. What does that mean, dual trained?
Well, open vascular and endovascular. So that before the current generation of residents where you can access the angio suite even during your routine rotations now, back then it was, I would say it was very much the purview of radiology.
Okay.
Radiology was doing angiography. It was very difficult for a neurosurgeon to get into the angio suite. So I spent 2 years working with radiologists, fantastic experience.
Those are like the Higashida days, right?
Yes, that's right, the pioneers. And then after that I was recruited back to Calgary and have been there ever since.
So open meaning like craniotomy, surgery in the operating room, endo meaning like in a biplanar suite where you're doing catheter work, kind of.
Correct.
Okay.
That's correct.
Yeah.
That's my practice.
What's your practice and breakdown like percentage-wise, open versus endo?
I would say about half and half. I'm pure vascular, but I'll treat aneurysms either with craniotomy and clipping. But for the most part, like ruptured aneurysms, we're trying to treat from a coiling standpoint now.
Okay.
Endarterectomy and carotid stenting, thrombectomy for acute stroke work. It's all really exciting stuff.
What's your favorite case to do endo? A favorite case to do open?
Well, I think aneurysms are both
sides.
Both. You'd have to look at it both ways, and I think that's the benefit of people having that experience in both realms to sort of look at things. Just like for spine, some things are better treated maximally, and some are better treated endoscopically. From like my colleague, Dr. Yang.
So shout out to Michael Yang from Calgary. Yes. Yeah. So. Look, I tell people this, and sometimes it offends endovascular surgeons. I say, listen, I think endo is like the new spine. Like if you go back 25 years in spine, the technology was just starting, right? Plates, screws were beginning. A lot of people did very well inventing devices. They often didn't disclose things, right? They used the brand names, like you hear people talk about like a pipeline stent. Yeah. And I'm like, endo is like the new I shouldn't say wild west, that's a bad connotation. It's the new opportunity. It's a new area, right? It's so exciting.
There's so much technological development going on. It's incredible. And that's what really pushes us as surgeons to do better things with better tools. So that's the way I look at it.
Yeah, when I look at what people are doing, and it's very interesting at our grand rounds or M&M, whenever they show the endo work, they're very, very technical. They're very much about, we did this, then we did this, and this feature was unique. And if you can't follow it, you're really lost, right?
Yeah. Totally. But all the principles are there. I mean, from a surgeon standpoint, you want to treat the disease, treat it effectively, treat it as safe as possible. So there are many, many commonalities within any subspecialty of surgery.
Very exciting. There's a company called Mirus in Atlanta, Georgia, and it's MIRUS, and I have nothing to do with them, but the gentleman who started it, he's an Indian gentleman, he built cardiac stents, and they were using new metals, molybdenum. If you look at the periodic table, that's why you gotta learn chemistry, guys. Like, molybdenum is different from a lot of the other stent materials that are used, whether it be titanium or whatnot. Yeah. And so they have a very strong structure, and then there's all the drug-eluting stents, right? So to me, it seems like endovascular is going to have a whole plethora of new technology, right?
Totally. I mean, there is so much advancement going on, whether with this large strategics, also with startup companies, really doing some really, really neat things.
Yeah, like in spine, there's a Korean company, and again, I have nothing to do with these companies that are, you put metal on people's backs to kind of heal them and fixate, and so they can, treat a fracture or dislocation or scoliosis. They have new implants that are made, I want to say out of is it manganese or magnesium that dissolve over time.
Yes.
So you can put screws in someone's back, and then 5 years later, those screws are essentially gone.
Yes.
Even
yeah.
though they were strong like metal, right?
Yeah, yeah. So a lot of different materials. Magnesium is also used for stents. Dissolves a bit too quickly. We've got some also ideas about how to develop the next generation of stents using bioabsorbable materials, but we'd have to stay tuned on that.
I like absorb. I did a lot of PLA, polylactic acid resorbables in my early career because I like the idea. Because I mean, there are some negatives in metal, right? Like metal is very powerful. It's a big advance, but can you help our audience understand why maybe metal is something that isn't always the best material? And by metal, I mean things like titanium or stainless steel, even though they work very well, right?
Yeah, I think there's, the next generation of devices from an endovascular standpoint would be potentially materials like polymer, potentially that would, after you cure the disease, cure the aneurysm, does it really need to exist there for the lifetime of the patient? And it has implications about whether or not they need to be on antiplatelet medications for a very long time, blood thinners, so to speak. Certain materials are more flexible, softer than others, so you can treat more types of aneurysms potentially. So it really is the sky's the limit here.
Yeah, I think about our current treatment, like if you broke your leg, they put a cast on your leg, but you got to wear it for the rest of your life, right? Yeah. So you mentioned biocompatibility. Yeah. You mentioned the flexibility, right? Yeah. Imaging
as well, absolutely. Metal obviously interferes with X-rays, so if you had different types of materials, potentially much more accurate with non-invasive tests like CAT scans and MRI scans.
And do you think drug elution's somewhere in there for brain work, or you think we're too far away with that?
It's on the horizon. I'll just say that. It's on the horizon, yeah.
Very exciting work. All right, John. Well, John, thank you for coming on the podcast. We have to have you on again.
Thank you.
Shout out to Calgary and all the folks there. Thank you for sharing this information with us. Sorry you guys didn't make the next round on the softball, but you know what? You guys are probably going to go do some groundbreaking research this afternoon. So
we exceed our own expectations. It's a super fun day. Super fun day.
Take care.
Thanks,
Enjoy
Mike.
New York.
Thank you.